Good morning. We're going to start the Department of Medicine grand rounds. And today the speaker is Dr. Forrest Arnold from the Division of Infectious Diseases. And most of you probably recognize Dr. Arnold because he's in charge of the General ID service here at the University Hospital. Then he interacts with all of you regarding infectious diseases consultations, as well as teaching residents, medical students, ID fellows. Probably some of the aspects that you may not know about Forrest is that regarding his training, Forrest finished medical school in West Virginia, then did an internal medicine residency program and in University of Tennessee. And then he moved here to Louisville, that he was one of our ID fellows. And our ID fellowship program is a 2-year program with the option for the 3rd year to do research. And Forrest decided to start the 3rd year doing research. Really, he applied, or the division applied for a position to the Society of Healthcare Epidemiology. And he was doing a 3rd year fellowship doing research in antimicrobial stewardship. And through this, he started also his career as a clinical investigator. Going back to the training, Forrest also did the Master in Clinical Research here at the university, the CREST program. And at this moment, he's board certified in internal medicine and board certified in infectious diseases. And he's well trained. Well, I don't know well trained. We train him. I don't know well, but he has a lot of training. And then in the area of research, as I mentioned, he trained in clinical investigation. He has 15 manuscripts as first author in peer-reviewed journal. He has a total of 45 manuscripts in peer-reviewed journals. He has 4 book chapters. He's a reviewer for several journals, included Lancet. Then he's been very, very active in our clinical research program, even though his primary role as a faculty has been always service. And in the area of service, not only Forrest is running the ID service here at the University Hospital, but he's the chair of the Antimicrobial Utilization Committee, and he has been the hospital epidemiologist at the University Hospital since 2004. And this is one of his primary roles in service, being the hospital epidemiologist. Then he's in part responsible for all these good Joint Commission visits that the hospital has had in the area of infection control and antimicrobial stewardship and hospital epidemiology. Then this is just to give you an idea of the speaker today, that again is one of our own members of the division. And what Forrest is going to do today is, as the title mentioned, he wants to give us an overview of what is the role of the hospital epidemiologist in a BC University Hospital as our University of Louisville. Forrest.
Thanks. Hello, thank you. It's really a privilege to be here and speak with you today. I've spoke at national meetings previously, but what I don't do is go around giving grand rounds. So I made this lecture for you, and I hope you get something out of it. As you see in my title, it has the word epidemiology, and that's the study of patterns, causes, and effects of health and disease conditions in defined populations. It is the cornerstone of public health, and it informs policy decisions and evidence-based medicine by identifying risk factors for disease and targets for preventive medicine. Epidemiologists help with study, design, collection, and statistical analysis of data. And they also help with interpretation and dissemination of results, including peer review. Epidemiology has helped develop methodology that's used in clinical research, public health studies, and to a lesser extent, basic science in biological sciences. The major areas of epidemiological study include disease etiology, outbreak investigation, disease surveillance and screening, comparisons of treatment effects such as clinical trials. Epidemiologists rely on scientific disciplines like medicine to understand disease processes. They rely on statistics to make efficient use of the data and draw appropriate conclusions. They rely on social sciences to better understand proximal and distal causes. And they rely on engineering for exposure assessment. There's actually two terms. One is epidemic, which is the study of diseases that are seen at certain times but not others, like influenza. And then there's endemic, which refers to diseases that are usually found in certain places but not others, like histoplasmosis. I have no conflicts. I never do. Here's my outline. We're going to talk about the background of epidemiology a bit, and then present a case, and I'll talk to you about the role of the hospital epidemiologist from three perspective diseases, and then give a conclusion. It seems like all these grand rounds start with Hippocrates, and as I was preparing for this and reading about Hippocrates and reading some of his excerpts, I saw that he made keen epidemiological observations based on simple methods of investigation. He developed the medical approach by providing concise, accurate, and complete descriptions of actual clinical cases. And then it was 2,000 years of no contributions to the epidemiology world until Girolamo Francastoro, that's not how his mother said his name, he came along. He was the mountain peak in the history of epidemiology, perhaps unequaled by anyone between Hippocrates and Louis Pasteur. He said diseases are caused by transmissible, self-propagating entities, which is pretty surprising because at the time the competition was other things that sounded crazy, like witchcraft. You have a disease because of this superstitious thing. Also, religion, you have a disease because of the sin that you committed. And things like this. His theory was that there was these little tiny invisible things that communicate disease from one thing to another. Well, that sounds as crazy as miasma, which was the infectious vapor. But he was right. That was the difference between all the other people. Then was Galileo, was right after him. And Galileo's the one that said, I do not feel obliged to believe that the same God who has endowed us with senses, reason, and intellect has intended us to forego their use. You see, what had been missing until this point was the integrated and systematic process of these five things: empirical observations, quantitative description, hypothesis formulation, deductive reasoning, and empirical testing on new observational or experimental data. This integrated and systematic approach began with Galileo, but spread from physics to other branches of study. In biology, the combination of observation, experiment, and quantitative reasoning was the discovery of circulation of blood by William Harvey. And his culmination of work was in this book, An Anatomical Exercise of the Motion of Heart and Blood in Animals. Then there was John Grant. And what John did was he didn't just record deaths, so many deaths. He started to look at what were people dying from, how many were born. He got christening records from churches. And so his work moved from recording, counting, and accounting to quantitative analysis of the data. So an excerpt page from his book is this one. In the upper left there, you see a date circled. This is the week of May 5th. 350 people died that week in London, 29 of them from the plague. Then if you compare that to this week down here, about the same number of people died, 330, but 308 people from the plague. Those kind of observations propel you into asking questions. What happened in the spring that didn't happen in the fall? Why did so many people die in the fall from plague, but they didn't die in the spring? He looked at other questions as well, such as these days, as those days, murders always get a lot of media attention. And so what he looked at was to see just how many there were. And what he found was that homicides were actually rather rare. They were just talked about a lot. He also looked to see that Boy-to-girl ratio was about the same, but more males were born and more males died by 1 year of age, so that the time school age came around, there was the same amount in each grade. Then all these men and the contributions they made laid the groundwork for John Snow, who solved the cholera epidemic in the 1800s in London. So what he found was that cholera was due to a pathogen in water that's infected by stool. And so he did two things to help that. He moved the water intake for London farther up the Thames River, and he took the handle off the pump that was associated with so many deaths. I went into this outbreak in detail last time I gave Grand Round, so I'm not going to do it this time. The concepts that are used to solve community outbreaks, though, are the same concepts that we use to solve hospital outbreaks. So the history, that's why it goes back so far. And that's what I'm going to talk about today. Now I'm going to do a case, and I'm going to start with the end of the case instead of the beginning. It's about Klebsiella pneumoniae. I want you to know, especially the students that remember, that it's a gram-negative bacillus, that it causes about 15% of infections in the ICUs, and it has increased resistance to carbapenems. It is a lactose fermenter like E. coli and Enterobacter, which is unlike Salmonella, Shigella, Proteus, Pseudomonas, right? And these mortality rates with resistant Klebsiella now are up to 50%. It has the propensity to cause outbreaks in hospitals, and the CDC identified what's called Klebsiella pneumonia carbapenemase in the year 2000. So to remember what a carbapenemase is, on the left here is a beta-lactam. This is penicillin. And here is the beta-lactam ring. Shortly after we had penicillin, the pathogen made penicillinase, so that it was resistant to penicillin. So there are different side chains that you can stick on a beta-lactam, and it'll make a cephalosporin or a beta-lactamase inhibitor or a carbapenem. So we made cephalosporins, and then we made beta-lactamase inhibitors. So beta-lactamase inhibitors with the beta-lactam, that's an extended spectrum antibiotic like piperacillin tazobactam. Then the pathogens made an extended spectrum beta-lactamase, ESBL, if you've heard that abbreviation before. And so then we have carbapenems, which are good for ESBLs. But then we've got these KPCs that are resistant to everything, unfortunately. As with most nosocomial pathogens, multiple drug resistance offers inherent selective advantage, which allows such organisms as KPC to persist both in the flora of hospitalized patients and in the hospital environment in which antibiotic usage is widespread. So KPC has the capacity to colonize patients and stuff. Here you see the ring around a sink drain, and here's a GI tract. The carriers of people with KPC in their GI tract are silently colonized for long periods of time. These silent carriers act as reservoirs for continued transmission that makes spread difficult to control and outbreaks difficult to stop. Furthermore, KPC can survive for several hours on the hands of hospital personnel, which likely facilitates nosocomial spread. So here's the case. It's a 43-year-old female known to have KPC who was transferred from New York City to the NIH Clinical Center in Bethesda. They knew she had KPC when she got there. She was placed in a private room in contact isolation, where staff and visitors were required to don a gown and gloves for entry. Her length of stay was a month, and she was in the ICU twice for 24 hours during that time. So here's where she came, here's where she left, and then she was in the ICU 2 short times. Even after the patient was discharged, throat and groin surveillance cultures were obtained from all ICU patients at admission and twice weekly. 2 weeks after discharge of the patient, another patient tested positive for KPC in a tracheal aspirate. The 2 patients never shared a ward at the same time. Surveillance culture negative patients remained in isolation after transfer from the ICU until negative cultures were obtained. But outbreak. 19 infected patients. These yellow patients all died. 7 of them were directly attributed to KPC. So 1/3 of the patients in this outbreak died from a hospital-acquired infection. This is a horrible pathogen. How did they stop it? Well, they did what we already do a lot of, and that's hand hygiene, and we preach gown and glove use. They also restricted people going into the rooms and patients going out of the rooms. They had dedicated equipment for single patient use, like our Fisher-Price stethoscopes. They had extensive cleaning of shared equipment. So if you just have to use your stethoscope, you'll want to clean that when you get out. And it doesn't hurt to use the Clorox wipes that we have up on the floor. You will remember to clean more than the bell of the stethoscope, because the tube actually also touches the patient. They did double cleaning of vacated rooms with bleach, and a private company was hired, if that wasn't enough, to decontaminate the ICU and all rooms and equipment with hydrogen peroxide vapor. So let's talk about the role of an epidemiologist. First of all, you have ULH, and at least today, the president is James Taylor, okay? Now, under him are 12 vice presidents. One of them is going to be the president next week, Ken Marshall. But another one is Kay Lloyd, who's the vice president of quality improvement. Under her is the director of clinical quality and patient safety, which is Linda Humble, and then the epidemiologist. This is a contracted position, the epidemiologist, and I'm not an employee of the hospital. I'm an employee of UL and ULP. The epidemiologist has 3 roles: infection control and prevention, antimicrobial stewardship, and employee health. In infection control and prevention, this is a committee, and it's chaired by Julio Ramirez. The epidemiologist is there, and then there's the infection control and prevention director, which is Linda Goss, until tomorrow. This is a position that is going to have to be replaced, and as she can attest, this requires a lot of work. There's other nurses in this committee, and administration is there. It makes sense that Kay Lloyd participates, and we get input from environmental services, engineering, other ID doctors, including pediatric ID, internal medicine, microbiology, multiple nurses, nursing directors from the ICU and from the floor, and the antimicrobial pharmacists. Now, the roles are to perform surveillance, report diseases. So if you have a patient with one, infection control does it automatically. There's device-related infections that we keep track of, whether it's a urinary catheter, a blood catheter, or an endotracheal tube. We are in charge of isolation, hand hygiene, and we get input from engineering, environmental services, and we keep the OR sterile. We keep the OR sterile in several different ways. First of all, there's construction sometimes in one OR, and we need to make sure that the OR next to it remains sterile. We also look at the antibiotics that patients are given just prior to their procedure, make sure that they're within a half an hour, depending on the antibiotic and depending on the procedure. We also limit flash sterilization. Then there's the antimicrobial utilization committee, where the epidemiologist is the chair. There's large pharmacy input, which makes sense. Again, infection control, infectious diseases input. There's an internal medicine representative, and of course, microbiology. Now, this has several roles. We make local hospital antibiotic guidelines that we derive from national guidelines. We have disease-specific guidelines like community-acquired pneumonia for the hospital. We monitor antibiotic use policies, such as antibiotic lock therapy, if you want to try to save a port. We generate an antibiogram newsletter, and we review antibiotics for formulary as this committee reports to P&T, Pharmacy and Therapeutics. Then there's employee health, where the director is Diana Schweikart. She has some nurses, and of course, there's some roles that I'm involved in. She does a lot more, but there's influenza vaccination of all the employees. We take care of PPD monitoring, and I see all the employees that are positive. And then any employee that has a needle stick or there's bloodborne pathogen exposure. There's 2 achievements in employee health in the last few years. One of them has been the increased employee vaccination rate. As you see, it's been going up over time. It was 78% this year, which is the highest ever. The red line, however, is the goal, the CMS goal of 90%. So we feel like we will be there in a couple years. If you were here 20 years ago, you may remember that there was a latent tuberculosis outbreak, and that was with a patient who had TB, but whoever admitted them didn't know they had TB. They diagnosed them with community-acquired pneumonia. And so what happened was they weren't admitted to a room with respiratory isolation, and they spread their TB to several employees, and the number of employees with a positive PD conversion went way up. And then we instituted the policy, that was before even I was here, that if you're going to admit somebody with community-acquired pneumonia, you do it to respiratory isolation and rule out tuberculosis. And since then, you can see that the rate has remained rather flat. And 2012, this looks like it's on zero because it is. We had no PPD conversions last year. So I could go through this slide and go line by line about everything that the epidemiologist does, but I think instead of doing that, I'm going to talk about the whole continuum through a certain disease. And the first one is Clostridium difficile colitis. And this will be more interesting, I feel like. So let's talk about employee health with C. diff. A 53-year-old female nurse had abdominal pain, cramping, and profuse diarrhea. About 10 episodes per day, moderate volume each time, and malodorous. She denied having any antecedent antibiotics. She believes she acquired it from a patient. She was diagnosed with a C. diff infection by her PCP, who deferred to employee health, which means to me, when she may return to work. Well, C. diff is all over the place. We looked at actually the emergency database and found that it has 26 to 29 million records per year all over the United States. And 500,000 people presented to the ER with a diagnosis of C. diff colitis. This is work that is submitted by student doctors Smith and Worth, who may be here today. As you see, the rate is going up, and it's very possible to get C. diff in the hospital, but it's very possible to get it outside of the hospital as well. But this lady wants to know, when can I return to work? And the answer is not complicated. When her diarrhea is finished and she's finished with her medicines, then she could come back to work and then continue to carry on it as I'm sure she always did, which is wash her hands after she uses the bathroom. Now let's look at Clostridium difficile in antimicrobial stewardship. The antimicrobial stewardship team is headed by the Antimicrobial Utilization Committee, which I just outlined for you. It has 3 goals. They are to optimize antibiotic use in the hospital, maintain efficacy, minimize research, and minimize adverse effects. If you're in the outpatient setting, then you'll notice that you'll have conversations with patients who want antibiotics often. And so in the hospital, we have some of those same effects from physicians who want antibiotics often. And I'm not talking about not giving physicians antibiotics like we don't want to give our patients when they just have a virus. I'm not talking about iffy patients or even unstable patients in the ICU. For those patients, it's actually, studies have shown that the outcomes of patients are better to give antibiotics than to wait with an unstable patient. I'm talking about the stable patient on the floor who does not have a diagnosis. You don't need to be giving an antibiotic, and neither do I for those kinds of patients. Now, if you're in the ambulatory setting, I thought we might try to relate to Doc Martin and see how he handles this. I've been told the sound system is out, but we'll make do. we don't have to have his bedside manner. Now a question. Which antibiotic is associated with C. diff colitis in U of L hospital SICUs? Clindamycin, ciprofloxacin, cefazole, and cefepime, or all of the above? And I'm sure all of you would say all of the above, but let me change the question just a little bit. Which one is statistically significantly associated? You would think clindamycin, that has all the reputation, and the answer is actually cefepime. Okay, now I could change the answers a bit, and if I said somebody got all of the above together, that would be antibiotics with 3 different mechanisms of action. You've got a lincomycin, a quinolone, and a cephalosporin, and those 2 were found to be statistically significant. Dr. Sherrar and Cox and I did this study. It's a case control study. The objective was to determine specific antibiotics associated with C. diff. We had 67 patients. We matched 2-to-1 ratio for age, length of stay, and of course they were in the SICU upstairs. Antibiotics were chosen if they were given to at least 5% of the patients. And here's our results. What you see is a kind of a big difference between piptazo. There's also a big difference between cefepime, which you know is statistically significant because I just told you. Then it looks like maybe imipenem. There's a difference there in clindamycin, maybe linezolid. Well, here's the results. Piptazo was significant, and so was cefepime, so was imipenem, not clindamycin, not linezolid, and it was to vancomycin as well. So what does the antimicrobial stewardship team do? They look at every intravenous antibiotic prescribed in the hospital, and they see that it is optimized. And if it is, great. If it's not, then they make a recommendation about the choice or about the dose or something, and then they wait a couple days, and they see if the prescribing physician changes. If they do, then great. If they don't, then they make a reevaluation. And in fact, everybody gets a reevaluation because some patients develop renal failure and they need their dose changed, and maybe that's not picked up on. Some people finish their course of antibiotics and they're still getting them 10, 20 days later. And so you could see a note from the clinical pharmacist in the chart for that as well. We looked at this in 6-month intervals, and what we found were all the initial antibiotics by prescribing physicians was about 70% were optimal. And then we made our recommendations, and this went up to 90%. Now our goal is really not 100%. There's always exceptions to patients with guidelines, and we understand that. But you shouldn't have 60% exceptions. So from going from 70 to 90 told us that our work was needed, and that it was needed over time as well. It's not like you could just do it for 6 months and then everybody knows. So we looked at people who were just writing the orders initially, and then we looked to see, well, is there one group that we could focus our interventions on, because we don't have many resources, internal medicine or surgery. And what we found was that internal medicine accepted our recommendations 83% of the time, and surgery did 71% of the time, for a total optimization or compliance with internal medicine of 93% and surgery with 88%. Now, if you notice, this is statistically significant, but it's not clinically significant. They're both about 90%, and we kept our resources allocated across the board to internal medicine and to surgery. Let's look at C. diff in infection control. 60-year-old male alcoholic smoker with Hep C and gross hematuria, and ultimately a kidney biopsy which revealed a renal cell carcinoma presented. He was there electively for a right nephrectomy. Post-operatively, he had hypoxia, went to the ICU, or levo and linezolid were started. MRSA pneumonia, psychosis, worsening renal function were diagnosed, and diarrhea developed. He worsened further on hospital day 6. IV was consulted. He had abnormal vital signs. His abdomen was distended. He had palmar erythema and telangiectasias. His stool was positive for C. diff. His white count was 48. His INR was 1.9. Abdominal CT showed dilatation, air fluid levels in multiple loops of his small bowel, and a toxic large megacolon was there. A colectomy was performed which revealed pseudomembranes, and for you students, this picture on the bottom shows the pseudomembranes, And this is the colon of a normal patient above. Very significant. The pathology showed extensive mucosal necrosis and focal transmural necrosis of the colon consistent with fulminant C. diff infection. His metronidazole was changed to IV and oral vanc was given per NG tube. On hospital day 23, his condition worsened substantially and he died. This gentleman was admitted electively and left dead. This is a horrible hospital-acquired infection. Now, C. diff over time at U of L Hospital has, you see, trended down. But as of late, it's looking like it's starting to trend back up. In 2008, we had a bump. It worsened, kind of the opposite of the stock market, because then it regained some steam, and then in 2012, it tanked again. Now, all these numbers are hovering around 1. We're not dealing with a lot of patients here. But as an epidemiologist, I always want a downward trend in any infection. And so that is one challenge that we're continuing to do. Now, as you can imagine, over the years, we've instituted different interventions to improve this rate. Some of those interventions are permanent. For example, we put this sign on the door. It says, wash with soap and water instead of just alcohol when you leave. And so that's put on the door and it's there forever. We use sodium hypochlorite to clean the rooms, and that's instituted and it's always done. The other things we've done, education. We always do education to orientation in environmental services and to nursing and services, but people forget, so we have to keep educating. Now, people also get distracted, and so you have to re-educate. So these things that are kind of stuttering make it so that the trend can possibly go up instead of down, and we need to stay on top of that. And now we'll look at another example, MRSA, across the continuum of the epidemiologist. MRSA and employee health. 34-year-old male PT calls in sick to work because he's nursing an abscess on his arm. He went to his PCP where it was drained, cultured, and grew MRSA. He calls risk management because he thinks he got it at work from a patient and therefore the hospital should pay. They tell him that they will not pay for anything, but they will grant him sick days to recuperate. Risk management in turn calls you because they want you to talk to him about his infection. Okay, I like that phone call. MRSA, again, is everywhere. You see there's 58% in this 2007 study in community, and then the 13% here shows that it's community associated. Then there's a large chunk in healthcare associated, which is what we're used to seeing. Now, what should we do with this guy? Should we try to figure out where his MRSA came from? We would have to culture all his patients and compare it to his strain, and then culture all the people he had contact with outside of the hospital, and then culture every doorknob he touched. So then we could treat him, decolonize him, and then decolonization is temporary, maybe 8 weeks, and then it comes back. So after that's over with, he gets MRSA again. Maybe we should put him on workman's compensation until his decolonization kicks in. You see how we're going down a slippery slope here? All we do is educate about universal precautions. Wash your hands on the way in, on the way out. If you have a break in your own skin, cover it up. Now let's look at MRSA and antimicrobial stewardship. We have generated local guidelines, and we have vancomycin guidelines. There's lots of indications for guidelines. I don't need to tell you what those are. People know why to use vancomycin, but there's also items where it's discouraged. And that is, for example, routine surgical prophylaxis. Also, empirical antibiotic coverage after 48 to 72 hours when you don't have a MRSA positive culture. Prophylaxis for patients with central lines. It's not indicated when you have MRSA decolonization unless there's an allergy. And you don't use it for MSSA treatment out of mere convenience. One way to determine whether or not the antimicrobial stewardship team is making any headway on antibiotic use in the hospital is to look at how many antibiotics are prescribed. And at a place like this where an antimicrobial stewardship team has been in place for years, the best we can hope for is just a flat line. What you don't want to see is increased antimicrobial use. And so if you add all these lines up, you get generally a flat line. Yes, we see linezolid going down, but we see daptomycin going up. And so they kind of cancel each other out. Another way to look at it is to look at finances and to say, well, is the money attributed to antibiotics going up or staying the same? It may falsely go up just because antibiotics, new ones, are more expensive, but the use is what we're really interested in. We want to look at MRSA and infection control and prevention, and I just want to stress that that's the name of the department. It's not just infection control, it's and prevention. Just like the CDC, the official name is Centers for Diseases Control and Prevention. So we do that by protecting patients, by preventing disease. We use hand hygiene. We make the policy, we educate, we monitor, and we enforce that. This is a typical graph from in the infection control committee in a month. And the blue bar are the physicians who are washing their hands going into a patient room. The red bar is coming out of the room, and the green bar is the physician who does both. Now, if you look at this, this graph, it looks like we're teaching our trainees how not to wash their hands. Does it not look like that? I don't know if we feel like we're too good to wash our hands, too busy, but something's got to reverse there. If I was a patient, I would want to be a patient in this area. I don't want to be a patient who's attending or fellow or resident or student doesn't wash their hands. And before the students get too excited because you see how compliant they are, this is not at the top. Would you want to be a patient up here who has a student come in who doesn't wash their hands? Yes, they're at 95%. That's good. I need to tell you a story. I followed I just happened to be going to the bathroom and there was a student in front of me the other day. And so after we finished, I was heading to the sink. I thought, oh, I'll have a nice conversation. What rotation are you on? The guy came right out of the stall and right out the door. And I couldn't even speak. Upstairs on the floor, I have no problem. Somebody's coming out of a patient room, they haven't washed their hands. I'm like, hey, cowboy, wash your hands. But down there, it just amazed me. A white coat exiting the bathroom. So I finished. I looked to the left when I got in the hallway. I didn't see him. I looked right. Oh, yeah, there he is in the cafeteria. So if you hear somebody call you cowboy from behind and it's me, just head to the sink. We're also going to look at contact isolation. And this is something that we do. We put on gowns and gloves in the door, and I appreciate all of us who do that. And I know you're smart people, and what's going through your head when you're putting on that gown is yes, you're doing it, but you'd have a much better attitude if you understand why you're doing it. Is there any data to support why we're doing this? You want to know, show me the data. Show me the data for putting on this gown because it's inconvenient and hot. So let's go through the pathogen transmission first. What you have here is a guy, and he's got MRSA all over him. And this guy is a doctor, and he's getting it all over his hands. Time passes. Then the doctor washes his hands, and he doesn't do a good job. And then he goes and gets it all over this poor soul with a mustache. See, that's how the MRSA gets there. So Boyson family did several studies, and I want to outline these. He found that 65% of healthcare workers' gowns or uniforms, whatever they had on, were contaminated with MRSA after they cared for MRSA patients. So they cultured the gowns, and then they went and saw the patients, and they cultured the gowns again. 65% had MRSA on. So he did another study the next year. 40% of the gowns were contaminated with MRSA or VRE, which is communicated the same way after he cared for patients. And he found that the gowns prevented contamination of clothes beneath the gowns. So he cultures the gowns, he cultures the clothes beneath the gowns. Somebody goes and sees the patient, then he cultures the gowns, they have MRSA, he cultures the jacket underneath, it's clear. Then the third one is 69% of the healthcare workers' white coats who weren't wearing a gown were contaminated with MRSA or VRE after care for patients. And 27 of them were then transferred from the white coats to the hands. And where do the hands go? To that poor soul with the mustache, right? So let's look at this is all data from the mid-1990s. This really is a resolved issue, but I want to outline this for you. Remember I said that VRE is contaminated the same way, communicated as MRSA. Here's a sample outbreak of VRE. 250-bed hospital, about the size of this one. There was 37 patients, 13 were in the ICU, 7 were on one ward and had been in the ICU, 6 were on another ward and had been in the ICU, and 11 others had no affiliation with the ICU whatsoever. But they did a case control study and found that pulse field gel electrophoresis supported that all the patients, whether they've been in the ICU or not, were derived from the same clone. And there's only one way to give everybody the same clone, and that's with your hands. In fact, this outbreak did not go away until they added gowns to the private room and gloves that they had instituted to get rid of the outbreak. Here's a handful of studies, and what you'll see is that it's showing rates of patients becoming VRE culture positive when healthcare workers used gowns and gloves compared to gloves alone. And 4 of them showed lower rates with gloves and a gown, and there was one equivocal study. And I want to outline the equivocal study. It was a prospective study in a good journal. They had 2 ICUs. Each ICU had 8 beds. And then they kept track along the way. How many people acquired VRE? In the first ICU, 93 were admitted to that ICU. 15 of them already had VRE when they came in. That knocked them down to 78 patients, and 24 went on to have VRE. In the other ICU, 88 patients came in. 13 already had VRE when they got there. That knocked them down to 75, and 21 went on to get VRE. These rates were about similar, and so there was no difference. I want to say one other thing. The compliance rate with the gown and gloves in this ICU was only 79%. So that was one limitation of that study, and perhaps why there was not a difference. So let's talk about ventilator-associated pneumonia across the continuum now. And the epidemiologist is not involved when an employee has VAP. So we're going to jump to VAP in antimicrobial stewardship. The team keeps track of multi-drug resistant pathogens, such as gram-negative pathogens that are resistant to at least 3 classes of antibiotics, ESBLs and metallo-beta-lactamases, such as the carbapenemase that I talked about in the beginning due to KPC. So there's several things you can do to prevent pneumonia, ventilator-associated pneumonia specifically. One of them is to give a sedation vacation. Another is to raise the head of the bed, make sure they have DVT prophylaxis, stress ulcer prophylaxis, clean out their mouth. And as you see over the last year, all these things have improved at University of Louisville Hospital. So it's no surprise that the trend for ventilator-associated pneumonia has come down pretty nicely, I might add, over the last actually 2.5 years. Effective control of a pathogen requires a detailed understanding of how transmission occurs. PFGE helps to classify agents and thus understand its local and global dissemination. It has a couple limitations, however. High clonality may not provide sufficient resolution to distinguish intra-institutional spread, that is within the same hospital, from inter-institutional spread, that is from the hospital down the street, which must not be named, that has KPC. KPC isolates are highly clonal. The KPC at the beginning of the talk that I mentioned, 70% belong to one sequence, type 258. So, whole genome sequencing is emerging as the gold standard in bacterial typing. It helps to classify agents, and thus we understand its local and global dissemination. There's benefits. It's already been documented successfully to be used with worldwide epidemics, regional outbreaks, foodborne epidemics, and bioterrorism events. The turnaround time now is less than 2 weeks. So in conclusion, I want to say that you should see that the epidemiologist, how it's organized within the hospital, and that there are 3 main roles: infection control and prevention, antimicrobial stewardship, and employee health. At any one time, I might find myself in the ER or the OR or the neonatal intensive care unit or on the 4th floor where the air ducts come in because of any of these things. And what I did today was go over 3 example infections, C. diff, MRSA, and Dept. And I hope you've seen as a healthcare worker your responsibility in hospital epidemiology. And with that, I just have one more picture of advice. At this time, I'll take any questions you might have.
Thank you very much, Forrest. I mentioned to Forrest, please give us an overview and tell us what is that you're working every day outside seeing patients. I think that he did a pretty good job for us to understand the role of the hospital epidemiologist and how important. And I have to tell you that it's also, Forrest mentioned at the beginning of the presentation that the Division of Infectious Diseases has a contract with the university hospital. We also have to mention that the division of the University of Louisville Hospital Administration, we have a contract for more than 20 years to have a hospital epidemiologist here. When in other hospitals, people are still debating if it's supposed to be a position for a hospital epidemiologist. And Forrest has been working, has a lot of experience, but there has been an interaction between the University of Louisville Hospital and the Department of Medicine. And I think a great job explaining what it is that you're doing here every day. Any comments or questions, please? Yes.
That was an outstanding presentation. Thank you so much. I just had a question about any observations that have been made in terms of family visitor adherence to these types of infection control policies that you have in terms of gowns and gloves, because it seems like that's something that could obviously be improved upon based on my end of one.
The family complying, you mean?
Yes.
Yeah, at times, if somebody there are exceptions. If you have like tuberculosis and you live with this person and now they're in the hospital with active TB, then you're already exposed. And so you'll get your workup. So you really don't have to wear a mask if you're, and then people with MRSA, if they're only going to visit that patient, we say, okay, you don't have to have a gown. And, we wear a gown so that we don't take it to the next immunosuppressed patient. Is there a specific example that you're thinking of?
Well, I guess I've observed that sometimes I'll see patients in contact isolation, and there will be visitors who are not wearing gowns and gloves, or they do, and then they might not know how to take them off, or they don't wash their hands after they take them off, and then these people do go to waiting rooms where other people are, who might take bugs to family members of our patients who might be vulnerable.
Right.
So, I'm just wondering about, any evidence about, visitor adherence to these sorts of things, or, C. diff.
Yeah, not evidence, but if our MRSA rate wasn't going down, then I'd be more concerned about that specifically. If we happen to admit a patient with KPC, then everybody's going in a gown and glove. So it'd probably be more on a case-by-case basis. Who else? Yes.
May I, excuse me, if this is probably for all of you, because you are dealing with a patient, we are dealing with a family. And as Forrest mentioned, the family needs to understand, because usually the story of the family member is, I've been with my mother with KPC at home for 3 months. Now my mother is in the hospital, now I have to do all these things. We need to mention to the family member, we don't care about your mother. We care you bringing this to the other patient. Then when your mother go home, you still do your things, but here in the hospital, you cannot touch your mother and touch, as you say, something outside. Then they need to understand that it's not the family member, it's as he mentioned, the other immunocompromised patient. And this is a teaching from the primary physician to the family member.
Eleanor?
Yeah. Thank you, Forrest. That's actually a very fine lecture. I have 2 questions. The first one is, has anybody looked for outcomes from using that alcohol stuff repetitively over the years? And then the second question is, how do you deal with the excuse for not using isolation that I see all the time, which is either, oh, I'm standing in the room and I'm not touching anything, or oh, I'm just walking in to pick up my whatever, and then walking in and out. Because sometimes, I'll see like, a nurses in particular, just kind of walk in and walk out. And
Right.
I say something like, hey, I thought this patient was in isolation, or, oh, is this patient in isolation?
There's signs on the door, and it's easiest for me to draw that line at the threshold. If you're going across the threshold, then you need to have a gown on. If you're not touching the patient, it doesn't matter. We've seen that these pathogens get all over stuff, the bed rails, IV poles, anything in the room can have it on there. And so that's why people need to put them on, even if they're just running in for a second. Now, if there's some students huddled at the door right there so they can hear, I think that's fine. But once they're in, across that threshold, then that's different. I have walked in on at least 4 non-physicians in the last week, and they're doing stuff in there more than what you said, and they don't have gowns. And I got to tell them, you can't do this. Just do what the door says. Now try to make it simple,
Alcohol.
Oh yeah, alcohol. You want to know about your hands, or are the pathogens developing resistance to it?
No. I want to know what happens to people who use this day after day after day, year after year after year, many different times a day.
Yeah.
There's limited studies of absorption.
Absorption of alcohol. Okay. I'm an experiment in the making here, I guess. I don't know if any of them say that there's a negative consequence. I hear some people say it chaps my hands, and so the hospital provides lotion, for that kind of stuff. It smells bad, but it's excellent. As far as getting enough alcohol, if you see somebody and they're pushing their mouth, that's one thing, but not enough to affect your work that I've seen. Yes.
Very good presentation. My question is, the data you showed and the information you shared was from big hospital. I'm just wondering what happens with private practices and private hospitals. How much they are close to compliance or preventive measures in terms of...
So like a little 50-bed hospital,
Yes.
What their compliance is? I don't know what their compliance is, and people don't share, especially if it's bad. See, you might have some hospitals that share and they're good rates, but who's going to say, hey, we did a horrible job complying with such and such?
I go back to the idea that in these hospitals, all the responsibility it face is under the infection control nurse. And you don't have a physician dealing with a physician. Then you have a nurse trying to convince a physician to do something, essentially nothing happens. Then you need to have the collaboration. This is why I say it's so important to have the position of the hospital epidemiologist, and not just to, again, Forrest is not just telling you, show you the data, he analyzed the data, he published on the topic, then he has, we are talking science here. Then this is critical. If there is not a hospital epidemiologist, things are not going to happen.
I can tell you small hospitals don't have epidemiologists. They just can't afford them.
Even large hospitals.
Yes, some large ones. Yes.
Along those lines, for dialysis units, there's required CDC reporting infection control.
Yes.
For access related infections and types and stuff like that. Is there CDC required hospital reporting so that you guys can look at trends and stuff emerging?
It's starting out, and actually there are at least 3 infections. You can go online and see trends for Jewish, Norton here, so that's required. Not all the infections that I listed today are required, and so I'm not sure the administration wants this lecture on the internet, but some of them are. That's right. Catheter-related infections and ventilator-associated pneumonia are 2 of the newest ones.
Do you ever, are there hospital facility epidemiologists luncheons or whatever we get together and talk about trends? Because I know that like Airbus and Boeing engineers, they cross-report adverse problems and stuff like that.
Yeah, there is on a nursing level, but again, I don't go to those meetings, and what is told to me is that they don't share a lot of the data that's not required. And nobody wants to share, negative data. There was one more question in the back somewhere. Yes?
So have you cultured keyboards and touchscreens?
Not personally. We could, and of course they're not sterile, and they will have hospital-acquired infections, like they could have staph on them and that kind of thing. And so that's why you'll see when patients are transferred, they'll put the chart into a bag because they get all contaminated, that kind of thing. I'm sure they are, and we need to consider that they are. And even this hospital, it says to just consider the floor completely dirty in a sense. And I mean, you can never totally clean a floor. And so you're always tracking stuff around. So even in a room that's been clean, even though the floor's been clean, it's not clean as the rest of the room, even though they're wiping down the sides and that kind of thing. But we haven't cultured keyboards. We have cultured jackets before, but I'm assuming that they're infected. And that's one reason to wash your hands going into the room, which sometimes doesn't make sense to people that are thinking, I don't get infected till I'm there. Does that answer your question? Yes.
So, as you mentioned, one of the critical aspects of antimicrobial stewardship is treating the patient adequately, quickly, so you can reduce the viral burden of the organism in the environment. So now we have evidence in the New England Journal of Medicine from a randomized clinical trial that we have the magic bullet for C. diff, which is the stool transplant. So what's the status of the institute that's at the university?
We need to get multiple disciplines involved, because if I order it, then pharmacy's got to be there. So there was a recipe on Medscape yesterday, actually, to how to practically institute this into a hospital. And they said it takes multiple disciplines, and you have to decide whether you're going to dedicate or buy a new blender every time you do this, that kind of thing. So there should be a task force committee for that.
Wait, there's a comment from our GI
Yes.
colleagues.
We're going to do a surgical grade of grounds on student. I am with the Arnold program next month. We're going to talk about stool transplants.
Oh, perfect.
We'll give you that protocol, and we're starting to do that. We've done several already, and it works, and we'll kind of talk a little bit about that. I had a question about
I have to mention that in our infection control committees, here at the VA hospital, we've been trying to implement this for more than 2 years, because really this started 3 years ago. We know that, but again, as Forrest mentioned, the question is the implementation. I have to tell you that at the VA hospital now, the administration has decided to do it. And when the administration wants something to happen, it's going to happen. Now, finally, we have the support of the administration at the VA hospital. We're still trying to define what is going to happen at the university hospital. Yes?
So one of the other questions, because you mentioned the white coats, and you had posted white coats in Britain, and they don't allow jackets longer than the elbow, because they say the proper hand washing and no washes. Because the only article of clothing that never gets washed is the tie, and the tie sometimes go forward. If you're not wearing a left toe. And I was just curious that Britain, that's part of their infection control. They have no jackets longer, and that's why scrubs are also.
Right. So whatever is on the outside of you is going to get colonized, whether it's this shirt or my skin. So you could go in there buck naked, and you're going to have whatever's on the outside is going to get contaminated. So that's what needs to be cleaned. And when you can't clean it, then that's when you put the gown on. We don't actually in the ICU. We will swab everybody coming in to make sure that they're not MRSA positive and put them in isolation if they are. And that's in an effort to be proactive against transmitting MRSA to our sickest patients. So I'm not sure how much they use gowns over there. And that may be why. Maybe they just can't afford them. Which reminds me, if you're worried about your team and using up all these gowns, just put them on everybody who wants to go in the room, and we'll buy more.
And with this, I would like to, again, thanks Forrest. I remember that when we discussed, I asked Forrest to give a ground round. He said, but I just gave a ground round 2 years ago. I said, but 2 years in hospital epidemiology is like, things change so much. Then I'm sure he's going to be back soon to have a possibility to keep discussing the topic. Forrest, thank you very much.